So good afternoon and welcome to this session on patient-driven healthcare. We have an excellent panel arranged. If you've tuned into some of the other sessions today, you've heard about some of the challenges patients face in managing their diabetes. The experiences of people with diabetes hasn't always been at the forefront of innovation and research. Another issue that's not always been at the forefront is health equity. And although the rights to insulin were sold for just $1, today there are millions of people in Canada who can't afford life-saving medications such as insulin. One potential way to improve the patient experience and to improve health equity is to involve patients and members of the public in the research enterprise. And our panel today is going to discuss how that plays out, how patient engagement intersects with diabetes research and also clinical care in diabetes. And so it's a real pleasure to be able to moderate this session that's going to involve 3 presentations from our panelists and then some time for open discussion. Our first panel member is Dr. Catherine Whiteside. A University of Toronto graduate, Dr. Whiteside served as Dean of Medicine and Vice Provost, Relations with Healthcare Institutions at the University of Toronto from 2006 to 2014, and was recognized with a WXN Canada's Most Powerful Women Top 100 Award in 2012. It's my great pleasure to introduce to you Dr. Catherine Whiteside.
Thanks very much, Nav, and thanks to the organizers for inviting me. What I'd like to do today is briefly tell you about strategy for patient-oriented diabetes research, the focus on patient priorities. May I have the next slide, please? Just a little bit of history first. The emergence of patient-oriented research started actually in the UK in the 1990s, when the National Institute for Health Research established the program called Involve and later the James Lind Alliance. Next, the United States developed a very important program called Patient-Centered Outcomes Research and an institute that was launched during Obamacare launch in 2010. And this actually was a congressional authorization of a new NGO that provides over $300 million per year for patient-oriented research. And in Canada, we started in 2012 when the federal government provided funding to CIHR for the creation of strategy for patient-oriented research. And in 2016, 5 chronic disease networks were launched, including Diabetes Action Canada, the SPORE Network for Diabetes. And that particular network has engaged individuals with diabetes from across Canada in some very important research that I'm going to tell you a little bit about. The SPORE program engages patients, caregivers, and families as partners in research focused on their priorities. The program helps to transform the role of patients from a passive receptor of services to a proactive partner. And finally, the translation of knowledge into practice by engaging health system leaders and policy decision makers. Next slide. Diabetes, as you've heard from a number of presentations, is in fact in epidemic proportions. And in Canada, 1 in 3 Canadians either have diabetes or have prediabetes today. The diagnosis of diabetes occurs about every 3 minutes, and about 1.5 million Canadians have type 2 diabetes and actually don't know it. The impact of diabetes is really in the complications of involving multi-organs. And you can see in the diagram here that it is underlying 30% of strokes. It's the leading cause of blindness in working age individuals, 40% of heart attacks, 50% of kidney failure requiring dialysis. And it is absolutely the most common cause of lower limb amputations. And in vulnerable populations, the risk of these complications is much higher. Next slide, please. Diabetes Action Canada is a consortium across all the provinces and territories. It really is involving many researchers, many patient partners, and a number of funding partners. We have 11 programs, and I'm going to tell you a little bit about some of those programs and particularly emphasize the role of our patient partners. Next slide. The SPORE mission focuses on the quadruple aim in healthcare. That is to improve population health, improve the experience of healthcare providers, as well as the experience of patients, and to help reduce the cost of healthcare. And overall, the impact is meant to create a learning health environment. And many of our programs are truly focused on all of these outcomes. Next slide, please. So I'd like to introduce you to some of our patient partners. Alex is a patient partner who co-leads our Indigenous Peoples Health Research Directed program. He's a member of the Kananakwe community in Quebec, and he's a very strong advocate for improving youth wellness through Indigenous ways. Doug is a patient partner who co-leads our digital health program to improve diabetes care. He's lived with type 1 diabetes for many years, and he really is a strong advocate for the use of technology, importantly, the use of continuous glucose monitoring and insulin pumps. Next slide, please. So this is just a snapshot of our Indigenous Peoples Health program. We focus particularly on youth, and the goal is to prevent diabetes and its complications among Indigenous youth by improving resilience, promoting wellness, and reducing the risk of diabetes. And this program initially started in 5 sites in Manitoba. And during the collaboration with Diabetes Action Canada, it spread to 13 sites across Manitoba, Northern Ontario, and into Toronto. And this program has received additional funding from CIHR and now is rippling out across Canada to 30 sites. It has been profoundly successful in enabling youth to engage in healthy lifestyles and to prevent type 2 diabetes. We've also developed a learning pathway, co-creating with another SPORE network called ACHRU-CPP. This is the program to prevent chronic kidney disease, where we launched this program to establish culturally safe, patient-oriented research practices with Indigenous communities as partners. Next slide. One of the aspects of all of the SPORE programs is the engagement of patient partners in the highest level of governance. The governance of our network is called a steering council, and Debbie Sismore is one of the patient partners who is a member of our steering council. And she says, "I've been living with type 1 diabetes for 50 years and lost my sight 25 years ago due to diabetic retinopathy. As a patient partner, I will be able to use my personal experiences from living with this disease to provide insight to the council. I bring to the table the experience of the diagnosis, treatment, and ultimately the devastating consequences of diabetic retinopathy." Next slide. So our diabetic retinopathy screening program is to prevent blindness by developing a national retinal teleophthalmology retinal screening program. And this has been proven to be very cost-effective and accessible to marginalized populations. In Ontario, for instance, we've expanded our program from 6 sites to 46 sites, including rural and urban sites. We've published evidence that teleophthalmology screening is cost-effective and beneficial for diagnosing diabetes related eye disease in marginalized populations. We've identified barriers and facilitators to diabetic retinopathy screening among ethnocultural minorities and Indigenous peoples. And finally, we're developing the use of administrative data to invite high-risk individuals for eye screening through our community health centers. Next slide, please. One of the issues in Canada is the ability to use health information to identify those individuals at highest risk for adverse health outcomes. And we have now established a national diabetes repository using electronic medical record data from primary care sites from across 5 provinces to date. We have over 120,000 diabetic patient records now, and you can see in the middle column all of the data that we have collected and are now using for research in the area of prevention of diabetic complications. Importantly, this repository is governed by not only investigators and healthcare professionals, but 50% of the individuals on our governance who decide how to use the data for research are actually our patient partners. Next slide. So one of the issues in terms of utilizing data is to be able to get the right information to the right people at the right time. And actually the COVID experience has now revealed the importance of virtual care. And our group is now in the process of developing new care models to enable individuals in the community to connect to virtual healthcare teams through a care manager where data are shared among all of these individuals. And importantly, this approach is enabling care that is not just through medical treatment or education, which are all very important, but also to connect to community services so that for each individual, their social determinants of health can also be addressed. And this really is critical, particularly for marginalized and vulnerable populations. Next slide. So the expected outcomes and impact of our programs, and particularly our endeavor to launch programs in virtual care, are to establish a feasible and affordable model of comprehensive precision intervention for persons with diabetes to optimize outcomes and prevent complications. Our intent is to enable the use of digital health technology and health information integration to support primary care health professionals in the community, and to demonstrate the value of integrating community-based health and community services to address social determinants of health for persons with diabetes and to inform policy decision-making. So that's just a thumbnail sketch of a number of our programs, and I hope I've given you a flavor of how we've been able to include patient partners in our programs. Thank you.
Thank you, Dr. Whiteside, for that excellent first presentation. That was impressive, both in its breadth and depth. Now, pleased to introduce our second speaker, Dr. Maureen Markle-Reid. A University of Toronto graduate, Dr. Maureen Markle-Reid is a professor and Canada Research Chair in the School of Nursing at McMaster University. Her research focuses on designing and evaluating patient-oriented health interventions to improve outcomes for older adults with multimorbidity and their family caregivers. I'm really looking forward to your presentation, Dr. Markle-Reid. You might be muted still.
There. Am I okay?
Perfect. Thank you.
Okay. Sorry. So thank you, Nev. And it's a pleasure to be here. Thank you for inviting us to be part of the panel. And on behalf of Dr. Jenny Plow and our ACHRU Aging Community and Health Research Unit team at McMaster, I'm very pleased to present our work in patient-oriented research as well as patient engagement in relation to older adults with multimorbidity and diabetes. So the first question is, why are we focusing on older adults with with diabetes and multimorbidity. Next slide, please. So diabetes is the most common chronic disease in older adults, and we define older adults as those who are 65 years of age and over. And almost 1/4 of older adults have diabetes, which is predominantly type 2 diabetes. Older adults have the highest prevalence of diabetes of any age group. And in addition to that, 40% of older adults with diabetes have 3 or more chronic conditions in addition to their diabetes. As a result, older adults with diabetes and multimorbidity, defined as 2 or more chronic conditions, have higher mortality, reduced function, they have increased risk of institutionalization, poorer self-management, and they're also at risk for adverse events such as falls or medication errors compared to those older adults who just have diabetes alone. But despite the high burden of care for this population, older adults with diabetes and multimorbidity have often been excluded from studies of interventions designed to manage the care of this population. And as a result, there is very limited evidence for how to best provide care to this population. Moreover, the system is poorly designed to meet the needs of this population. The care for this population is often organized around single conditions, and that results in fragmented care as well as limited attention to the social determinants of health. Next slide, please. So the need for a program to address these existing gaps in the delivery of community-based services for older adults with diabetes and multimorbidity was identified by a group of older adults with diabetes and their caregivers who were part of a diabetes support group supported by the Guelph Wellington Seniors Association that was led by a peer support volunteer. And during these support meetings, these older adults indicated that they were having difficulty accessing services and that they felt they needed more support to manage their diabetes to ultimately allow them to remain independent at home. This group of older adults were remarkable in that they were committed to identify potential ways of addressing these gaps, but they recognized that they lacked research expertise and diabetes expertise in order to move forward. So as a result, a partnership was formed between the Guelph Wellington Seniors Association, researchers at McMaster University, and Diabetes Care Guelph, which was part of a larger primary care organization. And together they co-designed a community-based program that directly addressed the needs of this vulnerable group and their caregivers. And this program was we titled the Aging Community and Health Research Unit Community Partnership Program, or the ACHRU-CPP. And the overall goal of the ACHRU-CPP was to improve self-management of diabetes and multimorbidity. And it consisted of 4 components that were delivered by an interprofessional team consisting of a registered nurse and a registered dietitian from Diabetes Care Guelph, and a program coordinator and a peer support volunteers from the Guelph Wellington Seniors Association. And these components consisted of the team, specifically the nurse and the dietitian, provided regular in-home visits to these individuals over 6 months. They were invited to attend a monthly group wellness session that involved the entire team that was hosted by the Guelph Wellington Seniors Association. Monthly case conferences were held with the team to discuss the patient's goals. And finally, nurse-led coordination and navigation was provided to link clients to other health and community services. Next slide, please. So once we had developed this intervention in collaboration with patients, caregivers, and providers, we conducted a pragmatic feasibility study in partnership with Diabetes Care Guelph and the Guelph Wellington Seniors Association to examine the feasibility of implementing this program. And what we found was that the program itself was feasible to implement within the usual care setting by the usual providers. And we also showed that there was preliminary evidence of its effectiveness. So then, with additional funding from the Canadian Institute of Health Research and the Ministry of Health and Long-Term Care, we then tested the effects of the intervention further in 4 sites in Ontario and 3 sites in Alberta. And each of these sites involved a diabetes education center in Ontario or a primary care network in Alberta and a community partner organization. And the results of this larger trial showed that a 6-month community-based intervention, the ACHRU-CPP, compared to usual care, resulted in a greater reduction in depressive symptoms and improved mental health and improvements in health and self-management in older adults with type 2 diabetes and multimorbidity. And what we found also was that even when we included the costs of this program in the total costs, these benefits were achieved at no additional cost to society. Next slide, please. So I just wanted to show you that each of these studies have been published, and that the pragmatic trial that we conducted in Ontario and Alberta that provided further evidence for the effectiveness and the intervention and the feasibility of implementing the intervention in real-world practice really formed the foundation for our current work. And that is, the next step was to test the intervention further in more diverse populations, specifically populations who face inequities related to the social determinants of health, like low income, low levels of support, living in a rural region, and in populations of older adults with diabetes who were high users of the healthcare system, specifically high users of the emergency room as well as hospital. And we also were interested in examining the potential scalability of this program in more diverse regions and to develop a scale-up plan. Next slide, please. So this is a schematic diagram that shows the progression of our work, starting with the co-designing the program with patients, caregivers, and providers, to conducting the feasibility study and the pragmatic trial in Ontario and Alberta, to where we are now, which is conducting a pragmatic randomized control trial currently to test the intervention in 6 sites in 3 provinces, Ontario, Quebec, and PEI. So we have 2 sites per province. And in this study, we have strategically engaged patient partners in each step of the work. So starting with co-designing the intervention with patients and caregivers, which form the foundation of this work, and moving forward and engaging patients and caregivers as partners in all of the other steps. So not only did we expand both the breadth and the reach of our research to determine the effectiveness of the program, but we also moved along the continuum of engagement, of patient engagement, as defined by the International Association of Public Participation Spectrum. So moving from informing patients about the research, which means letting them know about the research, to consulting, where the goal was to obtain feedback from patient partners, to involving and collaborating, which involved working directly with patients to share decision-making power. Next slide, please. So we were so fortunate to have the opportunity to partner with Diabetes Action Canada in this next phase of our patient-oriented research project and program to secure funding to further test the ACHRU-CPP. So Diabetes Action Canada provided us with the funding, the expertise, and the connections to local, provincial, and national stakeholders involved in diabetes care, and helped us to connect specifically with primary care sites that serve populations that we were planning to target. So namely older adults with diabetes who were facing inequities related to the social determinants of health. And the involvement of Diabetes Action Canada was instrumental in the establishment not only of our CIHR SPORE primary and integrated healthcare network program of research, but also we became a goal group within Diabetes Action Canada that was focused on promoting independence in older adults with diabetes. Next slide. So in this next step of the work, we've assembled a very strong interdisciplinary team of researchers, patient partners, policymakers spanning 3 provinces, and reflect a variety of disciplines such as nursing, medicine, biostatistics, health economics, social sciences, epidemiology, and pharmacy. Next slide. We strategically engaged a number of collaborators as well as partners, so including policymakers from each province, primary care, and community partner organizations from each province who served as collaborators as well as sites. Next slide. And I just wanted to acknowledge the funding we have obtained for this phase of the work from CIHR, SPORE Network on Primary and Integrated Healthcare Innovations, Diabetes Action Canada, the McMaster Institute for Research on Aging, the Scarborough Health Network, and Scarborough Health Network Foundation Baxter donation, the Fonds de Recherche du Québec, and the Rousseau Québec SPORE PICN Network. Next slide. So I'm just going to go over the objectives briefly, and then I'm going to turn it over to Rebecca, who will talk more about the involvement of patients specifically. So in order to target high system users, we had to better understand what the characteristics of those users were. So our first objective was to understand specifically what are the characteristics of high system users, of older adults receiving that have diabetes and use the emergency room and the hospital frequently. We then work collaboratively with our sites to co-design any adaptations that were required to the program. And we did this in collaboration with older adults, caregivers, and providers. Another key objective was to examine and to better understand how to best engage patients and caregivers in the research process. Of course, one of our main objectives was also to further examine the implementation and effectiveness of the ACHRU-CPP on quadruple aim outcomes, as Kathy mentioned earlier, and to explore, that includes exploring patient, caregiver, and provider experiences, and finally to assess the potential scalability of the program and develop a plan for scale up. So now I'm going to turn over to Rebecca, and I guess to Nav to introduce Rebecca for the next slides, please.
Excellent. Thank you, Dr. Michael Reed. Excellent examples there. Dr. Rebecca Ganan is an assistant professor in the School of Nursing at McMaster University. Dr. Ganan is the patient engagement lead with the Aging, Community, and Health Research Unit. Dr. Ganan, we're looking forward to this third and final presentation.
Thanks so much. It's such a privilege to be here today. So Dr. Marco Reed has just shared with us our current objectives and design. And what you're seeing on the screen depicts how these objectives are addressed throughout our research program. So I'm just I know it's a bit of a busy slide, but I just want to orient you. If you see in the left, the blue circles, these are how the inputs from our previous work and how we've been building the evidence base contribute to the current research program. So the current research program involves 3 sub-studies. So the first is, as Maureen said, it's a population-based analysis that aims to identify socio-demographic, health, and health service use characteristics associated with high use of emergency departments among our target population. The analysis uses administrative data from the provinces of Ontario and Alberta, and the results of this study are helping us to better understand some of the potential drivers of high emergency department use and the specific population's impact on system resources. So the second study is the trial, which is cross-jurisdictional and multi-site and evaluates the implementation and effects of the CPP, in particular focusing on diverse populations and settings in 3 provinces. And the goal of this trial is to demonstrate widespread effectiveness and ways to adapt the CPP for diverse population subgroups and different primary and community care contexts. And the third study is focused on planning for CPP scale-up. And this study is reflected at the top of the diagram in the white arrows. And the research program was designed with scale-up in mind. So the ultimate goal of the research program is to develop a scale-up plan that provides a systematic and detailed strategy for large-scale implementation of the CPP in each study province. At the top and the bottom of the diagram, you see 2 gray boxes that are sort of running across, and that really reflects the patient and public engagement and knowledge translation. Together, they are a central feature of the research program, and I think one of our greatest strengths. So throughout each sub-study and the governance structure are engagement spaces. And these spaces are critical opportunities for patients and policymaking partners to influence adaptations to the ACHRU-CPP in ways that reflect the needs and priorities of patients and evolving policy landscapes. And we know that our landscape is quickly evolving, so it's important that we're able to be a bit agile to reflect those changing environments. I'll talk a little bit more about our governance structure in just a minute. But for now, I'll bring your attention to the blue circle that's sort of in the center to the right of the diagram that shows you that towards the end of our research program, we plan to have patient, public, and policymaker forums in each province, and that will help with building our scale-up plan. Something unique about those planned deliberative dialogues is the opportunity for patient partners, patient perspectives, as well as practice and policymaking perspectives to be brought together simultaneously, which in other instances, we know deliberative dialogues don't always have those shared spaces. Sometimes those deliberations happen at separate tables. Ultimately, we think that having these multiple intersections of influence and opportunities for knowledge exchange will support scalability of the ACHRU-CPP and will help ensure that the model is aligned with current policy and practice landscapes, and ultimately improving diabetes care models and outcomes for older adults who are living with diabetes and health and social complexity. So I'm going to shift, next slide, please. I'm going to shift this conversation a little bit to share with you about how we've kept patient and public perspectives central to the work that we do. So we know how important it is to involve patients as partners early in design through planning and implementation stages, that if we can do that, that it leads to better results. So for this research program, it's been particularly important at this stage to engage a diversity of patients and caregivers to tell their stories and to guide the research. So we've really purposefully engaged diverse patient and caregiver perspectives across different geographies to explore urban and rural perspectives, as well as a range of gendered, ethnocultural, socioeconomic, and experiences with the healthcare system and managing diabetes. To achieve this, we needed to really create a roadmap to connect our engagement goals with achieving optimal results. Next slide, please. So this is the governance model that I was mentioning earlier. So we wanted to share with you a little bit about how we've engaged patient partners in our research program. Patient partners are embedded throughout the governance structure, from the cross-provincial steering committee that's at the center in white, and it provides guidance on all research directions and the evolving scale-up plan. Patient and caregiver research partners are also key members in the local community advisory boards in each study site. In those advisory boards, patient partners are reflective of the study population in each community and engage with local health and social system managers and providers to inform local implementation and adaptations. And I think it's important to highlight as well, not only are they members of the committee, they also have taken on co-leadership roles. So we have in these CABs, we have patient partners together with an organizational partner who are leading these CABs with administrative support from the research team, but really the ownership is with the community partners. And these boards that help shape, they have helped to shape interventionist approaches to engage with local patients and connect participants with the health and social services they need. They've also been important in terms of establishing shared tables for partners to foster relationships and to strengthen their collaborations across settings and organizations. They've been instrumental in navigating implementation challenges and also fostering collective impact among those who can positively influence sustaining the intervention if the intervention is found to be effective. Patient partners have also been engaged in our study one, from guiding variable selection to playing key roles in interpreting results and crafting messages about what we've learned about high system users based on the priorities of people living with diabetes and with a focus on modifiable or avoidable complications of diabetes. As I mentioned earlier, we're also evaluating our engagement strategy, and in a focus group with the Community Advisory Board, we heard this quote from a patient partner. I appreciate that the team's inclusive of the patient voice at all levels of project design, the research questions, what will constitute the rollout, and I think that they've demonstrated, sorry, I'm just going to ask you to advance the slide. And I think that they've demonstrated a really elevated sense of engagement and patients as equal partners. It's really person-centered. So the ACHRU-CPP intervention is patient-centered, and we also strive to parallel this in our patient and public engagement strategy. Next slide, please. So across sites and sub-studies, it was important to ensure that we were creating these environments that were engagement capable and patient-oriented throughout the research program. It was important that we were all on the same page with this. So some of the ways that we've achieved this were establishing a patient and public engagement working group. And this included site leads, provincial research coordinators, and the co-investigator leads for the community advisory boards. We established key points of contacts so there was an individual who was the key point of contact in each province, and that person would serve to be the go-to person for patient partners and was responsible for recruiting and orienting new partners and played important roles in building trust, building understanding of the research, and also understanding patient partners' lived experiences with diabetes and care delivery. Some of the things that we did to establish this was to develop a Moodle site so that all team members would have access to the co-developed tools and resources, including our engagement guide, role descriptions, a facilitator guide, how to manage honorariums, and other important resources to support CAB implementation. The working group offered opportunities to share engagement experiences across sites and also achieve cross-jurisdictional capacity building. Something worth mentioning is that we also use tools such as the Health Equity Impact Assessment tool to support recruitment of diverse stakeholders and enhance our implementation strategies. Next slide, please. I just want to highlight some of the additional resources that we've used and to foster effective working relationships and to integrate patient partners' expertise with other practice policy and research expertise in our team. Some of these tools were developed with our ACHRU research partners, and these include orientation materials, role descriptions, videos, and brochures. So a variety of modalities for people to really appreciate what their role meant and how they might contribute to the research program as we were onboarding them. Central to relationship building, it's been so important to have ongoing communication, to have reciprocity and respect, and ensure that we're closing the loop with partners on how their contributions have been used and how they're valued. I really want to especially highlight the need for structure, but how important it's been to be flexible and responsive in engaging partners who themselves are managing diabetes and other health challenges or may experience fluctuating caregiving demands. Next slide, please. So we've successfully implemented this multifaceted engagement strategy that's allowed us to align our opportunities with patients' interests. So our patient partners, what their interests are, what their expertise is, because we know they bring rich expertise from their personal and professional lives. And our patient partners have been engaged and made meaningful impacts on all of our studies and have also been involved in dissemination strategies. Often when we're presenting, we co-present with a patient partner, and we also look for co-authorship opportunities if people are interested. So we are one of the things that we're doing is we're evaluating both implementation and impact of the trial, but also importantly, tracing and documenting the impacts of our evaluation strategy. Next slide, please. So we've gained key insights into patient engagement and the needs and priorities of diverse older adults living with diabetes and multimorbidity. We've been on a steep learning curve, and we continue to learn. And we continue to grapple with how to engage those who face the greatest health inequities, both as research partners and creating inclusive environments, and also engaging people, these individuals as participants in the intervention study. As Dr. Whiteside mentioned earlier, we've also been grappling with the shift to digital approaches to engagement and digital approaches to care delivery within the ACHRU-CPP delivery model and the integration of virtual care, sometimes with better success than others. We're becoming more skillful with respect to implementing patient engagement, but also in our understanding of how to best evaluate the impacts of engagement on research, on partners, and ultimately on older adults who are living with diabetes. And we've learned that a fulsome engagement strategy, as you can probably guess, requires both human and financial resources. Next slide, please. So through our broader engagement approach and thinking about our partnerships with policymakers, organizational leads, and health and social service providers, as well as our patient partners, we've been building capacity and creating changes that are outside of the primary focus of the study. Some of these are hard to capture and measure, and yet we've heard powerful impact statements about the value of an integrated care delivery model with healthcare and social service community partners. We've learned about the value of learning about the social determinants of health. It's been eye-opening for some of our community advisory board organizational partners to learn about the impacts of social determinants of health that their patients face. And these are individuals who would just be normally presenting to diabetes care and then go home to their lives, and really gaining great appreciation for the impact of the social determinants of health. I think we've also heard about the impact of how the program has shaped care delivery in their broader diabetes programs, but also how it's contributed to improvements in the diabetes care model in their region or in their province. Most importantly, we've learned about how this model of integrated care supports a patient-oriented system. The outcomes achieved through this program have contributed to strengthening capacity in patient-oriented research beyond the study itself. What we've learned has helped to advance the science of patient engagement and research within the ACHRU-CPP network, but also through the provincial support units, for example, the Ontario SPORE Support Unit's Mira Collaborative for Health and Aging, and also the Pan-Canadian SPORE networks, including the Primary and Integrated Healthcare Innovations Network and Diabetes Action Canada. Next slide, please. So I just really want to thank you for the opportunity to share our work with you, and I'm really looking forward to the discussion this afternoon.
Excellent. Thank you, Dr. Ganan, and thank you to all three presenters. Our last presentation gave some really excellent examples, and I really like the multi-layered approach. So we're all looking forward to the discussion period, and I'm happy to be able to moderate. Please feel free to enter questions and comments in the chat box, and I'll be happy to put them to the panel members. And obviously, as moderator, maybe I'll take the prerogative to ask a couple of questions up front as we're accumulating questions and comments from the other participants. And once again, my name is Nav Prasad. I'm a family doctor and researcher at the University of Toronto. And one of my areas of interest is health equity. I wonder to the panel members, maybe starting with Dr. Ganan, how do you find patients and members of the public to work with in the research enterprise? I think there are a lot of researchers out there who are not currently working with patients and members of the public, and it's not clear exactly how you would start doing that. So how would you find people?
Yeah, that's a good question. And I have to say, we definitely have a number of different ways that we've identified individuals. I know that through our partnerships with Diabetes Action Canada and some of the other networks within the SPORE fabric, we've recruited through some of those networks. We also have over the number of years that we've been doing patient engagement, we have had partners who have come, who have been previously participants perhaps of the intervention studies and who've been interested in contributing as a partner and have sort of shifted in roles. When we were looking at the local community advisory boards, we really tapped into the expertise and the networks of our organizational partners as well. So, for example, I'm a lead on one of the community advisory boards. And so we partner with, community health centers, social services, some of our community-based partners, as well as our diabetes education centers to identify potential partners and to help us to identify them and potentially recruit them, or at least start the conversation so that we can actually have a little bit more fulsome explanation about what that entails.
Excellent. Thank you.
Maybe I can add, Nav. Diabetes Action Canada, as I mentioned, we have over 90 patient partners who are quite engaged with research development, but we also have relied on specific communities to organize patient partner groups from across Canada. For instance, our Indigenous Circle is composed of representatives from across Canada that they have organized themselves. And we also rely on our relationship with not-for-profit organizations like Diabetes Canada, as well as the Juvenile Diabetes Foundation, who have important patient partner opportunities as well. So as Rebecca said, there are multi opportunities to engage patient partners.
And the only thing I would add is,
sorry.
Oh, sorry. I was just going to add, it's interesting because we have partners in a number of our different studies, then sometimes we've been reaching out to those partners to say, do you know anyone who might be eligible? And that was, in one way, we actually knew someone in one capacity, and then they said, oh, I actually also would fit that capacity and had been a caregiver of a loved one with diabetes, but has been much involved in sort of the dementia care research and world. And so it's interesting as then we learn even more about our partners through some of these outreach activities.
I was just going to say now that one of the challenges in recruiting patient partners is that often older adults are not familiar with research. And so they're not clear on what is actually going to be involved and a little nervous about being tied to a project. And so one of the things we've done is we've been very clear right up front about the roles and responsibilities of our patient partners by developing actually a role description and being really clear about the fact that they will be paid for their participation and that we'll be very flexible in terms of their involvement. We understand that their situation does change, either their situation from a health perspective or caregiving perspective, and that we can be very flexible with respect to how they're being involved and how they want to be involved, so that there's a match between their interests and expertise and the needs of the research. So that, I think flexibility is key, and being clear.
Thank you, very important. I'm happy to keep asking questions of this really knowledgeable panel as other participants think of questions or comments to put in the chat box. I guess building on that question, just thinking about health equity, I mean, is there ever a risk that in putting resources into supporting patient engagement, that we could actually undermine health equity if we don't properly engage with disadvantaged patient populations or populations of the general population?
Absolutely, Nav. I think you heard the evolution of the work of the Aging Community Health Research Group, and it is the final or the most recent pragmatic trial now that is really focusing on more vulnerable populations, and that was quite deliberate. But you're absolutely right. We must ensure that we have representation from all of the diverse populations in Canada to really address their needs. We need to hear what their needs are and to be able to address those urgent health challenges with our research programs.
And we know from the research that this population we're studying is underrepresented because two reasons. One, researchers are reluctant to or don't have the resources or perceive to have the resources to engage them, or they simply can't engage them because of the barriers that exist. So there's a lot of reasons why, but it's so critical to have their voice integrated into this research. I mean, they are the high users of the system, and their voice needs to be heard. And we need to listen to that voice, and we need to integrate their perspectives so that the interventions we're developing are meaningful to them and will have an impact.
And I think I would just add, as I talked about, or Maureen and I talked about study 1, which is focused on those highest system users. As we were talking about so just recently we've been talking about crafting sort of key messages for lay audiences, and our patient partners were really instrumental in helping, in saying, we can't just paint this picture, like not changing the data, but also saying, there needs to be some messages embedded, that if we're sharing this with the public, that people don't feel further stigmatized or marginalized, and that people recognize that there are some things that can help, and there are supports available for people, and that there are, so it was really thinking about the crafting of the messages and not people feeling like, okay, now that we know this, where does that leave me? That there are ways to better support people through integrated care delivery models. So that's just an example of thinking about how not only are you engaging people in the research program, but how are we sharing messages that don't, further stigmatize this population.
Mm-hmm.
And we've learned quite a bit from our patient partners in terms of how to engage them. In fact, our patient partners are now publishing a manual for our researchers called Do's and Don'ts. And that is their opinion and their expertise and their experiential knowledge of how to engage them meaningfully in our research programs, both the development, the implementation, and evaluation. And they have become our most important assets and our most important advocates.
Wow. That's great. Yeah, I'd be interested to see that document. I remember when we were proposing to engage patients in a project, one of the investigators said, well, we should give these patients some set of rules so they know exactly how to behave. And so I like that.
It's just the opposite.
Yeah, great.
It's how the researchers have to behave.
I love it.
Yes.
And I'm happy to continue asking questions. You're also welcome to the participants to enter questions or comments in the chat box, or you can just show yourself or speak up. Dr. Whiteside, I wanted to ask you about one of the practical barriers to engaging patients is you ideally want to do so before you get started, but sometimes you don't have research funding before you get started. So there's this chicken and egg problem. So can you talk about some of the resources that are out there for researchers who are interested in doing this, but don't know how to get started and don't have the resources to get started?
Yeah, that's a great question, Nav. And there isn't a lot of, there's not an easy answer to that, but certainly in the healthcare system, we know that many of our institutions, our hospitals, and other organizations have developed patient groups who wish to be engaged. And so I would suggest that anyone interested in starting a research program look to those organizations that already have patient partners engaged and sort of latch on to those opportunities if possible. But you're absolutely right. When we first started, actually even before we had our funding, we were very fortunate to work with some patient engagement research experts. They actually did a pan-Canadian survey of individuals with diabetes, and they were able to provide information to us about what the most important concerns of Canadians with diabetes had even before we got started. And then we were able to, through a similar survey, recruit individuals from across Canada to be part and parcel of our patient engagement group. So it requires sort of a deliberate strategy, but the good news is that more and more individuals are being invited to hospital patient groups and other venues to be engaged in this kind of work with researchers. So the researchers need to look for those opportunities and reach out.
And I would just add, I know, obviously we've just described, Dr. Whiteside leads this large pan-Canadian network and really impressive group of partners. And we've engaged, we've been really, fortunate to engage quite a number of partners in our research program, but been involved in a number of capacity building workshops for early career researchers or research trainees or people who are really just starting to try to dip their toes in the water in this patient-oriented research world and sort of hear these expansive strategies and then think, okay, well, how do I even start if I can't do it in this full way? And I think it's really, as Dr. Whiteside said, just encouraging people to think about where are some of those opportunities to start and build. Dr. Marco Reed talks about it starting in a really grassroots way and being connected with those communities and being able to start and then build. You can build the research program as you build on those successes. And so I think, encouraging people to start to engage partners, and maybe it's starting with a couple of partners and then gradually building, the diversity and perspectives over time, but not hearing something like this and letting it deter you from even starting, because it's so important. And it's important that the health system, we're doing health services research, and it's important the health system actually reflects the needs and priorities of the people who are being served by it.
Another opportunity that Diabetes Action Canada is launching very soon is a portal system for individuals with type 1 diabetes to sign on to learn more about research in type 1 diabetes in Canada. It's going to be called Connect T1D. And it was co-designed with a patient partner who has a lot of expertise in technology-enabled communication. And we are very anxious to enable this access to for people with type 1 diabetes to learn more about research opportunities and patient engagement in these research opportunities in Canada. So that's just another example of how we can begin to engage patients.
Excellent, thank you. Maybe the last question could be about the other end of the spectrum now, thinking about the research outputs and impact. So how can engaging with patients and members of the public help ensure that the research does, in fact, end up informing a change in clinical practice or a change in public policy?
Well, I think to start, in our research program, we involve patients in not only co-designing the intervention in one local region, but adapting it so that it fits within a local setting. And I think that's key, is having patients and caregivers involved in determining how it needs to be adapted so it is feasible to implement within the existing system is absolutely key. And being able to identify where are those barriers and facilitators and how could those be addressed systematically. That's where our patient and caregivers have been most instrumental. And I think that's a key factor that's going to contribute to scale up.
And I would say, something that we've heard from our patient partners is really appreciating the opportunity to have their voices, their experiences brought to policy tables and shared in those arenas. And sometimes we've brought patient partners with us to those kinds of arenas. And then on the flip side, from a policymaking perspective, when we've done that when we've, brought some of our partners, they are the most important people in the room. That's who they want to hear from. They want to hear, because they don't always have an opportunity to hear from people with the lived experience who are actually managing these conditions that might be addressed by the policies or programs that are being created. So I think that that's so important to bring the interactions together and have those opportunities for knowledge exchange, because I think it's truly the path forward.
Yes, my experience with this particular group has been a real eye-opener, because as you've heard, in their governance organization, there's a mixture of patient partners, healthcare providers, researchers, and policy decision makers. And when you have the voice of the patient at that table repeatedly, giving the message, particularly to policy decision makers and health system leaders, it's incredibly powerful. So I think that's a real success factor.
Mm-hmm.
Yeah, I agree. And I have also found that when we're meeting around the table with policymakers and patients or members of the public, I think the person who people want to hear from the least is the researcher, and definitely the patient and member of the public. I think have everyone's attention as they absolutely should. So I'll just make sure there aren't any other questions or comments that we should get to. I have already learned so much from the presentations and this really interesting discussion. So it's my pleasure to wrap things up by first thanking all of you for tuning in to the panel today and for your engagement. And thank you very much to the conveners and organizers for pulling us all together. And most of all, thank you to our three panel members, Dr. Catherine Whiteside, Dr. Maureen Markle-Reid, and Dr. Rebecca Ganan. It's been a really enlightening panel discussion. Thank you very much.